Assalamu alaikum. Let's talk about D-xylose test. In a short, if we want to interpret a case with D-xylose test, what we have to remember, D-xylose, normal D-xylose means there is intact mucosa. So in normal D-xylose test, there is intact mucosa, so increase urinary excretion of D-xylose. But in abnormal D-xylose test means abnormal mucosa like disrupted mucosa. Think about intestinal pathology. Okay, this is the D-xylose test of proximal small intestinal absorption. If somebody is having D-xylose, increase intestinal absorption of D-xylose into the blood shown via high serum level. There is minimal fecal excretion and increased excretion of D-xylose in urine. That is, it is shown via high urine level. So there is high urine level. So this is normal D-xylose test. So minimal fecal excretion, high urinary excretion for normal condition. But in abnormal D-xylose test, decreased intestinal absorption of D-xylose into the blood. There is a high fecal excretion and low excretion of D-xylose in urine. Okay, first we will read a question. This 45-year-old man comes to the clinic. Why? Due to chronic diarrhea. He almost lost 7 kg of the weight. Over the past year, he has no blood in the stool. A 24-hour stool collection show fecal fat content is more than 10 gram per day. So stool microscopy shows fecal content more than 10 gram per day. Stool microscopy shows no pathogens and no leukocytes. Serum electrolyte renal function are normal. The patient is given 25-gram oral D-xylose solution, which is a monosaccharide, and his urinary excretion of D-xylose is low. After 5 years, urinary excretion of D-xylose is 1.2 gram only. It is below normal. Normal is 4.5 to 7.5. After 4 weeks of treatment, like after 4 weeks of getting rifaximin, the D-xylose test, rifaximin is a gut sterilizer. Um, the D-xylose is repeated. It is again the urinary excretion after 5 hours is only 1.3. So D-xylose is again low. So looks like as abnormal D-xylose and urinary excretion is low. Looks like any intestinal pathology. Looks like celiac disease. Okay, this patient has chronic diarrhea, steatorrhea, weight loss suggesting of malabsorption. There is diarrhea, steatorrhea suggestive of malabsorption. Celiac disease is the common cause of malabsorption. Is characterized by atrophy of the intestinal villi. In the atrophy of the intestinal villi in the proximal small bowel due to exposure to gluten containing wheat product. It is common in patients in northern descent and prevalence increases with age. The most important words, the D-xylose is a monosaccharide. D-xylose is a monosaccharide that can be absorbed in the proximal small intestine without degradation by pancreatic or brush butter enzyme. So D-xylose that can be absorbed in the proximal small intestine without degeneration by the pancreatic and brush butter enzymes. It is subsequently excreted in urine. In the D-xylose test, the patient is given oral uh, dose of D-xylose with subsequent assay of urine and venous blood. Patients with proximal small intestinal disease like celiac disease can absorb the D-xylose in the intestine, and urinary and venous uh, D-xylose level will be low as in this patient. But by contrast, patient with malabsorption due to enzyme deficiency, if malabsorption due to enzyme deficiency like chronic pancreatitis, will have normal D-xylose test. So malabsorption, is it due to pancreatitis or enzyme deficiency, or is it due to celiac disease? These can be differentiated by these D-xylose tests. So a false positive D-xylose test, low urinary D-xylose level despite normal mucosal absorption, can be seen if there is delayed gastric emptying, if there is impaired GFR, if there is glomerular function, if there is SIBO, small intestinal bacterial overgrowth, where there is false positive D-xylose test characterized by alteration in the small intestinal flora due to abnormal intestinal anatomy or motility, leading to bacterial fermentation of the D-xylose before it can be absorbed. SIBO is treated with rifaximin. Therefore, it is unlikely in this patient whose D-xylose test results did not change after following rifaximin. So, it is the most likely diagnosis in here is a celiac disease. An intestinal lactase deficiency can cause diarrhea, abdominal pain, flatulence after consuming milk or milk product. However, fecal fat and absorption of D-xylose will be normal. In intestinal lactase deficiency, the fecal fat and the absorption of D-xylose will be normal. Crohn's disease, which is characterized by transmural inflammation of the GIT, the most commonly caused in the distal ileum. Patient may have steatorrhea due to abnormal absorption of the bile as salts in the distal ileum, but D-xylose is absorbed in the proximal small bowel. So, as D-xylose happens in the proximal, D-xylose is absorbed in the proximal small bowel and is unlikely affected. So, the D-xylose is a monosaccharide that is absorbed in the proximal small intestine without degradation by pancreatic or brush border enzyme. So D-xylose is a monosaccharide which is absorbed in the proximal intestine, but it does not degraded by pancreatic or brush border enzyme. So patients with small intestinal mucosal disease will have impaired uh, absorption of D-xylose. Patient with malabsorption due to enzyme deficiency will have normal absorption of D-xylose. And in false positive D-xylose, like in SIBO, we need the antibiotic therapy. If after antibiotic therapy, if D-xylose is normal, then you should think about the small intestinal bacterial overgrowth also. So this is a very high yield topic, D-xylose test. Usually not done in nowadays, but it is very helpful. Hope you enjoyed.